Hello friends, today we are going to discuss about the quality indicators in the ICU. So first quality indicator is standardized mortality rate. Mortality rate are not often indicator of performance, even if those are often referred to. However, mortality rate related to the prior prediction is a sensitive indicator for comparison. SMR allows comparison of actual performance of the institution with predicted performance based on the average mortality as expressed by national and the international data. Risk of death varies with the severity of the disease state, age, and comorbid condition. Crude mortality, therefore, is not sensitive indicator. On the basis of influencing factor, SMR obviates the limitation of crude mortality as data from the large pool of patients with similar diagnosis and risk factor are analyzed to get expected mortality for that group of the patient. Data can be obtained from the national record or international record. Mortality rate can be obtained from the predicted models such as Apache, SAPS, and the MPM. SMR is very useful parameter often used to compare outcome in two or more group under study. It also gives an opportunity to individual ICUs for improving process and techniques. Formula for calculation risk adjusted mortality observed rate upon risk adjusted expected rate into 100. Observed rate is equal to actual death in ICU upon institution. Risk adjusted expected rate is the predicted death rate by predictive model. Interpretation if SMR is equal to 100, hospital mortality rate and expected average rate are the same. If it is more than 100, hospital's mortality rate is higher than the expected average mortality rate. If it is less than 100, then hospital mortality rate is lower than the expected mortality rate. Higher SMR Higher SMR does not necessarily mean that hospital is unsafe. Is not advocated. Now the morbidity parameters are iatrogenic pneumothorax, incidence of AKI in non-coronary ICU, and decubitus ulcer. Iatrogenic pneumothorax is the procedure-related pneumothorax. Formula is the number of pneumothorax upon number of cases into 1000. Benchmark is 0.83 per 1000 cases, that is 5%. Now the incidence rate of AKI non-coronary ICU. Description. De novo acute renal failure requiring renal replacement therapy or when the urine output is less than 200 ml in 12 hours or marked azotemia is defined as blood urea nitrogen more than 84 during patient's ICU stay. So renal failure increases possibility of the death notwithstanding whether renal replacement therapy has been initiated. Even the modest increase in serum creatinine level increase the risk of death by 70% when compared to the normal creatinine level. Formula for correction is number developed severe renal failure upon number managed in ICU into 100. Benchmark is severe ARA 5.7%, 10% developed ARA. Then decubitus ulcer. Decubitus ulcer or Peyer's are synonymous. So decubitus is derived from the Latin word decumere, means to lie down. Since the pressure sore can develop from other position, it is called as pressure sore. Prolonged uninterrupted pressures over bony prominence causes the necrosis and ulceration. So depending upon the tissue damage, the ulcers are classified into 4 stages. Stage 1 indicates superficial color change. Stage 2 indicates partial thickness skin loss. Stage 3, full thickness skin loss. And stage 4 denotes the deep and extensive tissue damage involving muscle, tendon, and bone. Deep and buttock sore represent 67% of all pressure sores. The formula for calculation is number of pressure sores upon number of cases into 1000. Benchmark is 3 to 11%. Then operational and procedural parameters. It includes length of ICU stay, compliance to protocol, and ICU readmission rate. Operation and the procedural parameter. Length of first one is length of ICU stay. Total hours and days patient management in the unit with the midnight bed occupancy are more accurate than the number of calendar days the patient spends in the ICU. Arithmetic mean overestimates the length of stay. as outlier both ways influence the mean length of stay very adversely. Median of length of stay can circumvent these problems. Length of stay is also influenced by the factors such as availability of intermediary care, discharge practices, and mortality rates. Appropriateness of using length of stay as outcome measure is therefore being reconsidered by the Joint Commission on Accreditation of Healthcare Organization. So, length of stay properly stratified on the basis of disease and condition and properly analyzed could be sensitive parameter, throwing up deficiency in process and technique in the ICU. Now, the rationality ICU beds are limited in any hospital. Rationalized use of the needy patient, therefore, is necessary. Length of stay therefore used to assess quality of care and resource utilization. About formula total occupied bed days upon number of patients in given time frame. Benchmark average length of stay in year 2001 Norfolk General Hospital is 4.36 in general ICU and 2.43 days in vascular ICU. Now compliance to protocol. Selected guidelines, protocol and treatment bundle in the unit to improve the patient care, resource utilization and reduce iatrogenic complication. Compliance to protocol, guidelines and treatment bundles are expected to improve patient care. Compliance to protocol could be absolute or partial. Formula for calculation number of times followed upon number of times expected to follow into 100. Benchmark is 90%. Now ICU readmission rate. Description: readmission to ICU within 24 hours of transfer during single ICU day. This is an indicator of post ICU care. Rationality: a zero admission rate reflects the more defensive approach by the ICU team, which increases the length of stay in ICU, causing risk of nosocomial infection, iatrogenic complication, and non-availability of the beds for deserving patients. Higher mortality rate of 1.5 to 10 times that of the control, and higher length of stay at least twice that of the control patient had been documented. Higher readmission rate indicates premature decision to shift out patients. So benchmark ICU readmission rate are around 5% to 6%. Now error and patient safety. Patient fall rate, medication error, adverse event, error rate, needle stick injury, and re-intubation rate. Patient's fall rate is defined as an untoward event which results in the patient coming to rest unintentionally on the ground or another lower surface. Rationality fall could be accidental, anticipated physiological, or unanticipated physiology. This is the safety issue for patient in ICU. Accidental fall could be morbidity, prolonged stay, and customer dissatisfaction. So formula is fall rate is equal to number of fall upon number of bed days into 1000. Now the next parameter is medication error. Medication error could be due to wrong prescription, dosing, and communication gap. Nationality: medication error occurs at mean rate of 19% in hospitalized adult. The need for assessing ICU medication error frequency is highlighted by finding that 78% of serious medical error that occur in the ICU were attributed to the medications. Formula is medication error rate, number of error upon number of bed days into 1000. Now the next is adverse event or error rate. Description: common ICU errors are related to the treatment, procedure, ordering and carrying out medication order, reporting or communication, and failure to take precautions or follow protocol. Rationality: critically ill patients are at high risk for complication due to severity of medical condition, complexity of treatment, polypharmacy, and technology-based intervention. Nearly all ICU patients suffer from potentially harmful events. Nearly half of the adverse events are prevented. Formula is adverse event upon error rate, number of error upon number of bed days into 1000. Benchmark the rate per 1000 patient days for all adverse event, preventable adverse event, and serious errors were 80, 36, and 149.7. Among adverse events, 13% were life-threatening or fatal, and among serious error, 11% were potentially life-threatening. Now, the next parameter is needle stick injury, a penetrating stab wound from the needle that may or may not be associated with exposure to blood or other body fluids. Rationality, needle stick injuries can cause transmission of the blood-borne pathogen. Needle stick injury can occur due to faulty handling of needle, syringe with needle, suture needle, and recapping of needle and faulty disposal. Annual incidence rate range from the 6 lakh to 8 lakh at global level. According to CDC estimate, 385,000 needle stick injury occurs annually in the US hospital sector. Approximately half of these go unreported. Although this is the minor injury, transmission of disease is a concern. It is the preventable injury, therefore adequate training to the healthcare provider is must. Formula for cannula calculation is incidence per 10,000 venipuncture. Benchmark 0.9594 per 10,000 venipunctures US national rate. Now the next is reintubation rate. Reintubation within 48 hours of extubation. Rationality, accidental extubation and subsequent reintubation can lead to prolonged stay, longer ventilation, and higher nosocomial pneumonia and mortality. So the formula is number of reintubated upon number of extubated into 100. Benchmark is 12.2% and 12%. Now, infection control is ventilator associated pneumonia, bloodstream infection due to central line, and urinary catheter related infection. So, the ventilator associated pneumonia, ventilated patient developing new capacity and also fulfilling criteria of ventilator associated pneumonia. So, rationality, ventilator associated pneumonia increases mortality and morbidity. It has cost implication as it increases the days of ventilation. Reduction in the incidence rate is desirable in ventilated patients. Now, diagnosis radiological sign more than 2 serial chest radiograph with at least one of the following. That is new or progressive persistent infiltrate, consolidation and cavitation. Clinical sign at least one of the following. That is fever with no other recognized cause, leukopenia. For adults more than 70 years of age, altered mental status with no other recognized cause. And two of the following, that is new development of purulent sputum, change in character of the sputum, increased respiratory secretion or increased suctioning requirement, new or worsening fever, cough or dyspnea and tachypnea, rales and bronchial breath sound, worsening gas exchange. Formula for calculation is number of patient with PAP upon number of days mechanically ventilated with endotracheal tube into 1000 days. Now next is bloodstream infection due to central line. Description, bloodstream infection rate is equal to number of central line related bloodstream infection per 1000 central line days. Rationality, bloodstream infection had emergent as a major killer. The estimated death caused by the bloodstream infection was 26,250 deaths per year, and it is ranked as 8th leading cause of death in United States. So the formula is associated bloodstream infection number of central line days into 1000. Now the next is urinary catheter related infection. Description, incidence of UTI per 1000 catheterized days in a patient catheterized in unit but not infected on the day of catheterization. Rationality, prevalence wise, urinary catheter infection is most common and it increases morbidity, cost and stay. Now, formula for calculation number of UTI upon number of catheter days into 1000. Now, the next is overall employee satisfaction. Description, satisfaction level of the staff working in a hospital or unit. Rationality, satisfied workforce gives the better outcome. Retention rate remains high. Formula for calculation is a 0 to 5 point scale where 1 represents lowest satisfaction and 5 indicates highest possible satisfaction. Now the next is patient satisfaction. Patient satisfaction is perceived parameter by the patient. Rationality, it reflects the performance of the hospital as a perceived by patient. patient satisfaction of the customer and is directly related to financial return to the hospital and also reveal reinstitution credibility in the population in the function. It also gives opportunity for improvement. Formula for calculation, no formula is available. Survey can be conducted by external agency to eliminate bias or to regular basis feedback form can be controlled for the analysis. Feedback form should be addressed areas like admission, registration process, facilities, food, interaction with nurses and physician, discharge process, personal issue, overall assessment of the care and other services. Feedback form with the 10-point scale can be used where 10 for the best possible service and patient give a rating for all questions. Overall mean score for each service is calculated from rating given by each patient. Thank you guys.